Coming up next, a hearing on health insurance and drug and alcohol treatment, held before the House Energy and Commerce, Consumer Protection, and Competitiveness Subcommittee.
Subcommittee will kindly come to order. I'd like to welcome all in attendance to today's hearing. And this hearing is a hearing that we will deal with a little-known side of a very familiar subject. All across the nation, the tragedy of drug abuse is front-page news. The outcry over dangerous crimes and wasted lives that stem from this epidemic has become literally a roar. Sometimes it seems that everyone has a proposal to stop the flow of drugs across our borders or to stop people from using them. As a matter of fact, the House of Representatives right today is taking up massive legislation, and this is as it should be. But the spotlight doesn't seem to shine on the problem of how we help people who already have fallen victim to drug or alcohol abuse. We hear about famous entertainers. We hear about famous athletes confronting their problems and seeking treatment, often as a condition to being allowed to return to the playing field or to the silver screen. But we never hear about how this treatment is paid for. We don't think about how the average person will be able to deal with the difficulty of seeking and paying for treatment. If the human need we are talking about isn't a compelling enough argument, I think it's appropriate that we look at the numbers. Look at the dollars. Nearly 18 million Americans are addicted to alcohol. Nearly 6 million are addicted to drugs. And when you take into account the host of problems that ride in the saddle along with alcohol and drug abuse, lost wages, medical costs, crime, accidents, it's estimated that drug and alcohol abuse cost this nation about $240 billion a year. Unfortunately, the vast majority of American addicts, nearly 85% of those on drugs or alcohol, go untreated. And for those who are treated, most of the cost is borne by governmental programs. Private insurance covers only about a quarter of what it is that's spent. On the plus side, private health insurance coverage of drug and alcohol abuse is much easier to get today than it once was. Today, 35 states require that health insurance cover treatment for alcoholism. About 17 require some coverage for drug abuse. Health insurance for these problems isn't cheap, but it is cost-effective because the health care costs associated with drug and alcohol abuse are staggering. On the average, the cost of drug or alcohol treatment is recovered in just 2 or 3 years after treatment is undertaken because of savings in other health care costs. It is, in effect, an investment that can pay off in the form of healthier people and lower doctor and hospital bills. Insurance coverage can also encourage abusers to seek treatment both by helping to pay the financial costs and removing some of the stigma that today might prevent drug and alcohol abusers from stepping from the shadows of addiction into the limelight of treatment. Treating drug and alcohol abuse is not easy. Not for the patients, not for the society. There is debate over how to treat the afflicted and who should pay. Clearly, private insurers must play an important role, hopefully a more important role. Today, we will start to explore what that role is to be. The fight to rid this nation of alcohol and drug abuse will be a long one and a hard one. It will require hard, clear thinking and new approaches. It is, however, a challenge that we cannot afford to duck. And I'm looking forward to hearing from our witnesses today with their thoughts as to how best we can deal with this problem. I'd be happy now to yield to the gentleman from Texas, Mr. Barton.
Thank you, Mr. Chairman. I commend you for holding this hearing. I think alcohol and drug abuse is, if not the most serious problem facing this country, certainly one of the most serious problems. As you indicated, we've got a major anti-drug bill on the floor this week in the House. I think these hearings will certainly build a record that perhaps won't be included in the bill before us today, but certainly in the years ahead will, and I commend you for holding the hearing.
Thank you very much. We'll proceed to our first of 3 panels of witnesses that we will hear from today. We are very pleased, and I would ask the witnesses to come forward, to have with us Mr. Wayne Thacker, Director of the Office of Substance Abuse Services of the Commonwealth of Virginia, who is here on behalf of the National Association of State Alcohol and Drug Abuse Directors, and Dr. Daniel Flavin, Medical Scientific Officer of the National Council on Alcoholism. Gentlemen, we welcome you to our committee. As with all of our witnesses, your prepared statements will be made a part of the record in their entirety, and you may proceed as you see fit. Sir?
Thank you. Good morning, Mr. Chairman and members of the subcommittee. Thank you for inviting NAZADAD to appear today and address the issue of insurance coverage with respect to alcohol and other drug abuse treatment. I am Wayne Thacker. I'm the Director of the Substance Abuse Services Office within the Virginia Department of Mental Health, Mental Retardation, and Substance Abuse Services. And I'm appearing on behalf and as a member of NAZADAD today. This is the National Association of Alcohol and Drug Abuse Directors. We're a not-for-profit organization whose membership is exclusively comprised of state officials designated by governors to administer the publicly funded alcohol and other drug abuse treatment and prevention systems. The National Association's basic purpose is to foster and support development of effective alcohol and other drug abuse prevention and treatment programs throughout every state. As was pointed out in your introductory remarks, Mr. Chairman, I know that you and your committee, or subcommittee, are already familiar with the range and complexity of problems associated with alcohol and other drug abuse. That it is a problem that transcends socioeconomic levels, race, sex, and age. And that there are a great deal of costs approaching the $240 billion level associated with alcohol and other drug abuse. One of these costs is increased medical care costs associated with disorders, illnesses, and diseases concomitant with alcohol and other drug abuse. These costs also do not take into account the personal suffering and individual tragedies which arise from alcohol and other drug abuse. Compounding an already catastrophic situation is the issue of the AIDS epidemic and the increasing greater demands for drug abuse services are being made by thousands of individuals who are IV drug abusers. These same individuals, however, are often informed that treatment is unavailable and that their names will be taken and placed on a waiting list, and they may have to wait 3 to 6 months before they can engage in treatment. Direct federal support for programs is a very important component for the full array of support for treatment services. However, between 1980 and 1986, direct federal support declined 40% during that 6-year period. Only in fiscal years 87 and 88 are increases documented, and that's due to the Anti-Drug Abuse Act of 1986, PL 99-570. However, when we take a look at that addition during that period of time, then we still fall below the level of federal monies needed to maintain the level of services supported by federal government 8 years ago. I point to the federal support for an express purpose is that, at least in this Commonwealth of Virginia, client fees and third-party pay represent approximately the same percentage of our total treatment system budget as federal support. So client fees and third-party pay are an integral and very important component in the array of support for treatment services. Most working individuals, private or employer-provided health insurance forms the foundation for their coverage. Many persons with insurance assume that expenses of alcohol and other drug abuse treatment may be covered in their policy. Tragically, not until persons seek treatment, they find out that the limits of their insurance coverage may be very restrictive with respect to alcohol and other drug abuse. Thus, these people with insufficient coverage often are call upon the publicly funded treatment services to cover costs of their treatment, adding to an already overburdened system. Today, when a person becomes ill due to diseases that are similar to alcoholism, such as chronic heart disease and adult-onset diabetes, and other chronic diseases such as cancer or most other health problems, that individual can usually rely on private health insurance to cover most of the costs associated with treatment of those problems. However, if the person is ill due to the diseases of alcoholism or other drug addiction, then treatment is often not covered unless mandated by the states. Many private health insurance policies include provisions that specifically exclude treatment for alcoholism or other drug dependency, or may restrict their coverage to the more expensive and restrictive treatment services provided in an inpatient setting, a hospital-based service, and will not include coverages for residential or outpatient treatment and less expensive freestanding non-hospital services. When the costs of treatment are not covered, many individuals do not enter treatment, and these people deteriorate, cause further problems for themselves and their families and society. And they will also incur additional medical costs for conditions related to their primary disease. Within the past 15 years, laws have been enacted in 38 states and the District of Columbia that either mandate the provision of benefits for alcoholism or drug dependency treatment services or require that health insurers offer such benefits for purchase. Since 1971, when the first law mandating coverage for alcoholism treatment was enacted in the state of Wisconsin, there has been a steady growth in the number of states which have passed laws. Most recently, in 1987, New York enacted legislation that mandates coverage for outpatient drug dependency treatment services. Attached to our testimony as Appendix 1 is a synopsis of the current status of relevant state statutes that mandate coverage and require the offering or coverage for purchase, or have no relevant legislation governing alcohol and other drug abuse. 6 specific provisions of health insurance statutes from these states include the following: inclusion or exclusion of health maintenance organizations, HMOs, the type of coverage provided, group or individual, the type of treatment setting covered, hospital, residential, and/or outpatient, and the type of individual provider covered, physician and/or other service providers, and then other requirements to ensure quality controls and specific benefit minimums or limits. And Appendix 2, attached to our testimony, provides information on each of these 6 areas. The recent legislation introduced by Senator Edward Kennedy and Representative Henry Waxman seeks to provide health insurance coverage to millions of Americans who have no health insurance or have coverage that is grossly inadequate. The members of NAZADAD share the concerns of the Congress in this regard and have devoted time, energy, and resources to securing appropriate and comprehensive health insurance coverage for alcoholism and other drug abuse in the public and private sectors and at the state and national levels. NAZADAD has long supported increased federal and state funding for treatment services for alcoholics and other drug addicts without health insurance. Because of our ongoing concern and commitment, we are dismayed at the current legislative proposals not only exclude alcoholism and other drug treatment from the benefit package, but preempt state-mandated benefits for alcoholism and other drug treatment in 38 states and the District of Columbia. If enacted as presently drafted, the minimum health benefits legislation will deprive tens of thousands of American workers and their families who suffer from alcoholism and other drug dependencies of adequate health insurance to finance treatment services. In addition, NAZADAD supports mandatory coverage for alcoholism and drug dependency treatment services for a number of other reasons, including the following: alcoholism and drug dependencies are diseases which treatment should be reimbursed by health insurance providers on the same basis as any other disease or illness. The provisions of benefits to treat alcoholism and drug dependency constitutes a responsible and effective and humane social policy in response to the enormous public health problem and suffering caused by alcoholism and other drug addiction. The provision of alcoholism and drug treatment benefits will, in the long term, cut costs and save monies for both insurers and subscribers, especially when the range of covered services include the lesser costly and effective residential and outpatient approaches. The reimbursement of alcoholism and drug treatment services by health insurers will reduce the stigma associated with alcoholism and drug dependency, improve accessibility to services for alcoholics and drug addicts, and may well save costs incurred for concomitant other health and medical disorders. The availability of monies from health insurers to reimburse alcoholism and treatment service costs will provide a broader and more stable financial base for treatment programs that have been supported entirely or primarily by government funds. In conclusion, the problems of alcohol and other drug abuse encompass complex health and social issues requiring varied solutions developed through cooperation of federal, state, and local governments, private business, labor organizations, and the American public. It's essential in considering ways to address serious health consequences of alcohol and other drug abuse that the provision of treatment and rehabilitation services be a top priority. All Americans should have access to alcohol and other drug abuse treatment at little or no cost for those who cannot afford to pay, and at reasonable cost for the millions of working persons with health insurance coverage. The members of the National Association of State Alcohol and Drug Abuse Directors thank you for the opportunity to testify before the subcommittee today. We look forward to continuing to work with you to improve our nation's health insurance coverage of alcohol and other drug abuse treatment.
Thank you very much. Doctor?
Good morning. My name is Dr. Daniel Flavin, and I'm the Medical Scientific Officer for the National Council on Alcoholism. I also serve as Chief of the Outpatient Alcoholism Treatment Program at St. Vincent's Hospital in Manhattan, and I'm an Assistant Clinical Professor of Psychiatry at New York Medical College. NCA is delighted to have this opportunity to testify on the importance of adequate health insurance coverage for treating individuals with alcoholism and other drug dependencies. This discussion is especially timely given the nation's current focus on fighting a war on drugs and congressional interest in the adoption of universal health care coverage. A comprehensive and effective approach to addressing the nation's drug problem must include provisions which will increase access to care for individuals with alcoholism and drug dependencies. Any universal health care plan which is to meet the needs of millions of Americans must include adequate coverage for alcoholism and other drug dependencies. Mandated insurance coverage for alcoholism and drug dependency treatment is a public policy which has proven effective. Insurance coverage increases access to care and lowers overall health care utilization rates, not only for the alcoholic individual, but for their families as well. Over the years, NIAAA has promulgated model benefit packages for alcoholism treatment coverage both independently and in conjunction with large insurance providers, including the Aetna Insurance Company and Blue Cross Blue Shield. Those studies have demonstrated that alcoholism treatment coverage is inexpensive and cost-effective, as it contributes substantially to a reduction in overall health care costs both for the alcoholic and his or her family. In 1975, the Joint Commission on Accreditation of Hospitals began to accredit both hospital-based and freestanding programs, thus helping to pave the way for third-party payments for alcoholism treatment. At the same time, national efforts led to the establishment of credentialing standards for alcoholism and drug abuse counselors and the development of a qualified workforce to treat these diseases. It is now increasingly recognized in the private sector by both employers and insurance carriers that the failure to provide third-party reimbursement is far more costly than the provision of benefits for alcoholism and other drug treatment. It has been found that alcoholics and their families use a disproportionate amount of inpatient and outpatient medical services for a variety of medical problems associated with drinking. The fifth special report to the United States Congress on alcohol and health contained a summary of the cost-effectiveness studies and concluded that, quote, despite some methodologic problems, these studies indicated significant reductions in medical care use and expenditures related to various kinds of alcoholism treatment, amounting to a 40% median reduction in sick days and accident benefits. Additional studies since that time has confirmed this conclusion. The fifth special report also concluded that, quotes, number one, Alcoholics and their families initially use more health care services than non-alcoholics. Number 2, this elevated demand can be reduced substantially by treatment for alcoholism. And number 3, the benefits of alcoholism treatment clearly outweigh its costs. Another NIAAA study showed actual premium savings of up to $6.22 annually as a result of alcoholism benefit packages, allowing for cost savings from reduced health care utilization and more appropriate diagnoses. Moreover, the more comprehensive plans not only showed the highest utilization and the lowest benefit payments, but the greatest premium savings. Perhaps the strongest evidence for the efficacy of insurance coverage for alcoholism and drug treatment services is provided by the number of states that have taken action to mandate such coverage. Since 1971, when Wisconsin was the first state to mandate coverage for alcoholism services, there has been a steady growth in such mandates, from 17 in 1981 to 22 in 1985 and to 24 states in the District of Columbia as of 1987. An additional 13 states have passed laws that require insurers to offer alcoholism and/or alcoholism and drug dependency treatment services as an option for purchase. Mr. Chairman, your own state of New Jersey has a progressive policy for alcoholism treatment that has been in effect since 1977. It mandates that policies must provide for detoxification, inpatient and outpatient treatment to the same extent as any other illness under contract. A number of health insurance plans in both the public and private sectors offer alcoholism and drug dependency treatment coverage as an option. Studies commissioned by the National Institute on Alcohol Abuse and Alcoholism of state legislative action have demonstrated that mandation is the only effective way to ensure coverage. Data from states with optional alcoholism and drug treatment coverage varies little from those where there is no statutory provision for coverage at all. Alcoholism and drug addiction are illnesses characterized by denial. Employees are unlikely to opt for alcoholism and drug treatment coverage. Mr. Chairman, I would like to comment on current legislative proposals to provide basic health insurance coverage for the millions of employed Americans who are uninsured. It is important to note that these proposals do not include explicit coverage for alcoholism and drug dependency treatment. Senate 1265 and House Bill 2508 were designed to address the plight of the millions of employed Americans who have no health insurance coverage. Both bills are silent on the issues of alcohol and drug treatment services and preempt all state laws which mandate coverage for these services. When Senate 1265 was marked up in committee, it was amended to include a mandate for mental health coverage. There is no discrete alcoholism and drug treatment benefit offered in the bill. There is no reference to alcoholism and drug treatment in the committee report. There is reference to the definition of mental health as presented in the International Classification of Diseases, 9th Revision, Clinical Modification, which does define mental illness to include alcohol and drug addictions. Although NCA and other field groups were delighted to see some movement toward the inclusion of alcoholism and drug treatment coverage in the Kennedy bill, the current proposal is fraught with problems. The history of inappropriate care to alcoholics, coupled with the high cost of such services, was the motivating force for the federal alcohol effort and the creation of separate and discrete services for alcoholism treatment. A discrete alcoholism and drug dependency benefit is an appropriate component of this legislation. Even if we are to assume inclusion of alcoholism and drug dependency under the Kennedy mental health benefit, the coverage outlined in the Kennedy bill may not correspond to an appropriate continuum of care for all individuals in alcohol and drug dependency treatment. NCA and the Legal Action Center have developed a model alcoholism drug dependency benefit. This benefit includes coverage for 7 days of detoxification services, 30 inpatient days, and 60 outpatient visits renewable annually. And a copy of this model benefit is attached to the written statement. We would recommend that the committee review this plan as a starting point in your deliberations on health insurance coverage for alcoholism and drug dependencies treatment. We would also recommend that you look at enhancing the Kennedy-Waxman proposals by supporting explicit language on alcoholism and drug dependencies treatment. We are deeply concerned that the current absence of specific mention of alcoholism and drug dependency treatment coverage in Senate 1265, now pending on the Senate calendar, may ultimately result in a determination by the regulatory agency or the courts that it was not the intent of Congress to provide mandatory coverage for these illnesses. In conclusion, Mr. Chairman, NCA would like to offer the following recommendations to enhance health insurance coverage for individuals with alcoholism and other drug dependencies. Number 1, an amendment to the Kennedy-Waxman bills, the Health Insurance for All Workers Act, to include statutory language requiring the inclusion of comprehensive inpatient and outpatient benefits for alcoholism and other drug treatment. Number 2, a mandatory comprehensive alcoholism and drug treatment benefit for all health insurance plans offering benefits to federal employees. Number 3, expansion of federal Medicare and Medicaid alcoholism and other drug treatment coverage to include reimbursement for services in freestanding residential facilities and enhanced outpatient coverage. And number 4, increases in federal funding through both the block grant and direct service grants, such as the NIAAA Homeless Demonstration Project, because governmental reimbursement mechanisms either provide inadequate or no coverage for the indigent. NCA believes that policies which increase access to care must be at the heart of any federal effort to address alcohol and drug problems in our nation. The adoption of these 4 recommendations would represent a significant step forward. Thank you.
Thank you very much to both of our witnesses. Let me right at the outset rise to the immediate defense of our colleague, Mr. Waxman, particularly, that as I suspect both of you know, I mean, his initiative along with Senator Kennedy is, even as far as it goes, is not having people strewn palm in its path. I mean, it's a very difficult bill to get through in its present form, and there hasn't been a lot of support in certain circles even to move that direction. And I'm sure the suggestions that you've made are meritorious, but we shouldn't be overly critical of the limitations of the bill, because even as limited as it is, it's not something that's getting a lot of support in certain circles. Let me ask both of you to address a problem that's been brought to our attention in that there is a sense in some circles, again, that mandated standards become the industry standard, and that, in fact, the treatment tends to gravitate towards that because of the reimbursement mechanism, and that works to the detriment sometimes of the individual's needs. As a matter of fact, in my own state, I've had attorneys come to me who have been representing individuals who are involved in drug abuse, and there is always the judge directing that they get the 28-day treatment. And then, of course, in some instances when, which apparently is part of our state requirement, when someone needs 60 days or if they need 15 days, they get 28 days because that's what gets paid for. Is there any legitimacy to that type of criticism of mandated standards?
Well, in response to that, I think that the treatment field is really moving toward the concept of treatment matching, that is, matching individual patient needs based on a clinical assessment of the patient with an appropriate treatment modality. The Institute of Medicine at the present time is undertaking a 2-year study, if not a little bit greater than 2 years, of the current alcoholism services field and what is available in this country, and it's a very extensive process that's currently underway. So those of us in the treatment field are very anxious to in awaiting their conclusions.
As a doctor, are you convinced that there are objective ways to evaluate the different treatment modalities toward the end of reducing that to a system?
I think there are. It is contingent on continued research in the field of alcoholism, alcoholism treatment, and the underlying etiology and exacerbating factors in the disease of alcoholism.
Let me ask, and rather let me just share with you an experience that I had just a few weeks ago. I went to the city of Newark, which is a city with a lot of problems in general, and a lot of problems particularly with regard to narcotics, and had a tour of a freestanding residential treatment facility, a nonprofit facility called Integrity House. And the problem there, of course, is the absence of capacity. I mean, they could take, in the city of Newark, they could use about 3 or 4 more Integrity Houses. And it was brought to my attention that there were particularly prisoners who were ready for probation if they could get into a facility such as this, because there wasn't capacity for. These prisoners were sitting in prison, obviously in very much more expensive modes of treatment, which we couldn't even call it treatment, and that you could make an argument that forget the humanitarian aspects, forget the medical aspects, on a sheer dollars and cents basis, if you had more such residential treatment facilities, you get those people into a better mode of treatment and save money, and then free up the units in the houses of incarceration for people who could better use them than these people who are ready for parole. I understood that in one of your recommendations, you were observing that you would recommend that Medicare and Medicaid be modified so as to provide for payments for residential treatment. Would that type of recommendation address the problem that I just described to you that exists in Newark, New Jersey?
Well, it certainly could. As I can tell you that as director of a clinical program myself at St. Vincent's Hospital, that we frequently receive inquiries from individuals who are about to be released from prison who are looking for outpatient treatment as well. So that that is another option that is present, not only residential treatment, but if it's appropriate for an individual being released from prison, outpatient treatment for that. And we do accept such individuals into our program.
Thank you. We yield to the gentleman from Texas.
Thank you, Mr. Chairman. I'd like to ask a question to Mr. Thacker. You indicate in your testimony about the role the federal government, to some extent, the federal government should play in this. Does your association have any guidelines in terms of percentages that payments federal versus state versus local versus individual? I mean, what, do you understand my question?
As far as a specific guideline, I don't believe we have any guideline or goal. I think our effort is to work with both the state, local, and federal levels in terms of increasing the amounts of money. As far as right now, what we're seeing is roughly 18% of the system across the states is federally funded, and about 50% being state funded.
And then the remainder is? And
then the remainder would be other sorts of funds such as donations, fund drives, client fees, third-party pay, and perhaps other sources of state and local tax dollars.
Third-party pay would be private insurance?
That's correct.
Okay.
That's correct.
But
some of our programs
right now, the
covered.
states are picking up the majority of the cost, 50%. If
that's correct. Yeah, okay. It's true in our state. I know that we're picking up 40% of the public system right now.
Dr. Flavin, what would you, I mean, you were very specific in what the federal government should do in types of coverage it should require. Would you care to put a percentage on what percentage of the cost we should attempt to pick up?
I'm really not prepared to do that at the present time, but I certainly will confer with my other colleagues in our Washington office to try to put something together for you in that.
I guess I would also have a question for you, Doctor, in that given the fact that even those that hold to the point that alcoholism is a disease, and I would assume the majority of the medical profession would hold that point today, it is an elective disease in the sense that if one never takes a drink of alcohol, one never becomes addicted. And given the disparity in the various state laws and how alcoholism is treated and the various insurance requirements, why should the federal government step in and mandate for all 50 states some of the specific requirements that you just suggested?
I believe that, well, to address the question, the comment that you made earlier, as alcoholism is an elective disease, alcoholism is a disease. I think there's no question about that amongst the majority of the vast majority of the medical community at the present time. The question, I think, for researchers in the future is it a unitary disease? That is what we call alcoholism today. Under the rubric of that name, may be 5 or 6 different types of diseases 50 years from now, depending on the research that we have down the line. it's our feeling that that alcoholism treatment needs to be mandated because, as I mentioned in the testimony, one area is that alcoholism and drug dependencies are diseases that are characterized by denial. So an alcoholic or even a family member will deny frequently that this is a problem, and frequently until it's too late. So by having mandated coverage, this would address this particular problem. So it's our feeling that, it's definitely that mandated coverage is very important. Would be a very important area.
Brings up another question, and then I'll yield back to the chair or to Congressman Nielsen. The statistics that I have indicate that the best treatment program is only at 30% effective. In other words, 70% of the time you fail if you go in for an alcohol rehabilitation program as we know it today. So aren't we a little early in beginning to mandate certain things if at the very best we're only going to get 30% effectiveness? Should we, and if we do mandate, should there be some inclusion that number of times through a particular program before private insurance doesn't have to pay, or the state doesn't have to pay, or whoever's paying doesn't have to pay? Because I mean, you know the statistics better than I, but the anecdotal evidence is that there are some alcoholics that go through these programs 4, 5, 6 times.
I can give you anecdotal evidence. One of, for example, one of my instructors in my residency program at the Mayo Clinic was a gentleman who had been through treatment 7 times, and it took 7 times for him until it really stuck. So, and there are frequently individuals that fall into that category, that it takes repeated treatments for there to be ultimate remission of the disease. And realistically, for some, as you mentioned, they do go through repeated treatment, and unfortunately don't make it in the end. On the other hand, I have some problems with when you quote studies, and not specifically referring to you, but just in general in the literature, that talk about treatment effectiveness. My question would then be, what is treatment effectiveness? How is that defined? And if,
well, is there one universally recognized treatment that you and other experts say we think this is the best, and 60% of the time it'll work?
No, there's not. There are several approaches or actually a number of approaches to treatment at the present time. And again, as I mentioned before, that where we are going in the treatment field is to really put emphasis on the individual, assess what the individual's needs are, and then match that person to treatment. So, for example, if someone comes in who is suffering from severe primary depression as well as primary alcoholism, they are going to likely require the need of a psychiatrist or a mental health service. If someone is coming in to a program who has a good family support structure, who is reasonably well motivated for treatment or has something to lose, for example, he's under threat of job termination or other coercion, that individual may do well in an outpatient program and not require the needs of mental health professionals. It gets into the debate about inpatient versus outpatient treatment, which is more effective. And clearly, in my opinion, inpatient treatment is necessary for many individuals, especially those who don't have strong psychosocial support structure, who are suffer from severe psychiatric problems, either primarily or secondarily as a result of their alcoholism, who may be suicidal or homicidal, or the socially disenfranchised, amongst other populations. So the treatment field is a heterogeneous field at the present time, and it's our hope that the Institute of Medicine study will shed further light on this and also move toward the direction of the treatment matching, which is ultimately where we hope to be and would be the best use of resources and funds. So,
well, Mr. Chairman, I know there are other questions. I want to yield back the balance of my time if I haven't exceeded it. I will make one editorial comment. As the Congress moves away, in the past, we tended to initiate programs, and we would also initiate payment schemes for those programs. We are now beginning to mandate programs that the private sector has to pay for. You know, we say what the coverage is going to be, but we say to our private insurance carriers and the corporations and companies that and the individuals that pay those premiums that they have to pay for it. And given the fact that there is not universal acknowledgement about just what is the most effective kinds of treatment and how successful those are, I would tread in this area somewhat reluctantly at this point in time. But I think it is good to build the record and enlighten the public on what the problems are, because if we can't determine the problems, we can never come up with solutions to solve those problems. And I yield back.
The gentleman would just yield just for an observation. Yes. That obviously we've gone through a period of time here in Washington when we have shifted the major emphasis as to what government should do or not do. And as was stated by one of the witnesses, the federal contribution over the last number of years has decreased, I suspect as a manifestation of the philosophy of a retreat from governmental, at least federal governmental initiatives. I guess the logical consequence of that is that if the federal government is not going to be paying for things because of some sense that the federal government does things in efficiency, real or fancied, that if the social policy is to be pursued, and hopefully there's a unanimous view that the social policy of dealing with drug problems ought to be pursued, then I suspect what we're finding is an alternative approach is being grappled for, and one approach being that the policy goal should be stated, and that the private sector ought to be charged with the mission of finding it, perhaps with some degree of flexibility to spell out more appropriately the way of dealing with the problem. I understand what the gentleman is saying, but I think the approach that's now being pursued in a whole host of different areas is the logical consequence of the philosophy that's prevailed, which is that the government shouldn't be spelling out the programs and paying for them. Let someone else deal with them, because that was part of the rhetoric that prevailed for the last number of years. But I appreciate the gentleman's point. Gentleman from Utah, Mr. Nielsen.
Thank you. You mentioned a couple of things I want to follow up on. You mentioned outpatient care. Is outpatient care a reasonable alternative to the 28-day period?
For some individuals, outpatient care is a reasonable alternative. Other individuals, the populations, for example, that I mentioned before, do require inpatient stay. In our program, for example, we have both an inpatient and an outpatient component, and frequently patients are admitted to our program, which is actually a 21-day program, and then to the outpatient program.
Dr. Flavin, how was the cost of an outpatient process compared with the inpatient, 21-day or 28-day, whichever you want to talk about? What would be the relative cost of an outpatient procedure?
It's difficult to say, because it would depend on the individual case and the length of time and length of treatment involved. And the other factor in that also is the fees, which vary from hospital to hospital. There are some agencies, for example, that whose fees would be higher for inpatient treatment than other
A lot of insurance policies are such that inpatient care is covered considerably, the hospital part's covered, whereas outpatient is not. Do you think the policy should be rewritten to allow outpatient and the health insurance cover that cost as well?
Definitely. I believe that's...
Are there some who go inpatient simply because they can save insurance costs?
No. I think that increasingly in the field, individuals are being assessed for their need to be in an inpatient facility, and if so, then they're admitted to that, but not to play the insurance game there.
Congressman Barton talked about the 70% times the time it fails and so forth, and you didn't agree with the statistics, but anyway, he mentioned that. Why should we perpetuate a system that fails 70% of the time, if that's the right figure?
Well, Again, it's how do you define success and how do you define failure? If 30% of the people who graduate from an inpatient or an outpatient program remain sober for the rest of their lives, that would be defined by most people as a success. Another percentage, and I don't have the figures in front of me at the present time, may have one relapse or more relapses in the following year. After a subsequent treatment, those another 30% of those individuals would then remain sober for the remainder of their lifetime. So it's not an all or nothing phenomenon. It's not a one-shot deal here.
How do you assess, either of you, Mr. Thacker maybe could do this, how do you assess the effectiveness of Alcoholics Anonymous as an alternative way to solve an alcohol problem? Is that effective or not effective? And if so, if it's effective, what's the cost involved there? Mr. Thacker, do you have an answer about that?
The Alcoholics Anonymous and Narcotics Anonymous self-help groups, I think, are an extremely important component in providing community-based support and self-help. Many of our treatment programs integrate Alcoholics Anonymous or Narcotics Anonymous principles, at least an introduction to that community support for the people going through their programs. And those organizations exist outside of any formal state or local governmental structure, and they present no public cost. But there, I think, are a significant number of people who require a more formalized treatment intervention at the very beginning of their treatment process, and then would benefit from the continued support in the community following that formalized treatment intervention. There are others who will not make it in an Alcoholics Anonymous or Narcotics Anonymous group and will depend on other types of community support.
Do you have any evidence, either of you, to suggest that the 28-day period is any more effective than the Alcoholics Anonymous or the outpatient?
I think that the 28-day period, again, has become a magic number. And would like to emphasize that,
pick your number, I don't care.
The individualized treatment approach, depending on what an individual needs, would be, I think, what both of us would recommend. As far as comparing the two approaches, strictly the Alcoholics Anonymous approach, strictly the formal treatment system approach, I'm not aware of any studies that have done that. I'm aware of studies that have shown that both are effective with certain people, but as far as a complete matching of people between the two approaches and then analyzing those results, I'm not aware of any study that's done that.
How much burden of responsibility should we put on the patient himself? I mean, how many relapses are we supposed to pay for? Is it a case-by-case type approach? Or?
I would look at it much the same as chronic heart disease or adult onset diabetes or other diseases that medicine is learning now has a heavy behavioral component associated with it. So I guess my recommendation would be, once we've decided how many times someone can be readjusted as far as their diet and insulin, be readjusted as far as their high blood pressure, hypertension, and chronic heart disease problems, then I would think that number would be an appropriate number to apply to alcohol and other drug abuse.
If there's no patient responsibility or insurance is all paid for, what's the incentive for the individual to try and do what he can to stay drug-free or alcohol-free?
Okay, I think as far as a co-payment, I think there's definitely room for a co-payment when co-payment is a possibility. And I know that in our system, in Virginia, in the public system, we require the assessment of client fees based on that person's capability at that point in time to participate in the cost of their treatment. About 16% of the funds that we collect to support our treatment system comes from client fees and third-party pay. So I agree with you that there is a definite benefit in the investment of a client, not only by way of coming into a treatment facility, but by way of personal investment. There's a benefit there.
I have other questions, but I'll submit them in writing, Mr. Chairman.
Thank you very much. Let me just ask two final questions. As you can probably sense, not only here, but in other words, there's not going to be uniform appreciation of some of the points that you've made from a standpoint of medicine, from the standpoint of health. And in some instances nowadays, the only way you get things done is by talking about dollars. How confident are either of you in this the suggestion you've made in your prepared remarks about cost effectiveness of this type of treatment that can be translated back into a pure economic argument on behalf of what it is that you're both advocating. Are there documented studies? Can someone come forward and say that if we put X amount of dollars in a Medicaid mode or a Medicare mode of treatment, that will result in reductions in Medicaid or Medicare dollars because we're cutting off the need to treat related types of illnesses by treating the basic component of a particular person's illness, which is the alcoholism or the drug abuse. How confident are you that if someone took the time and the energy that there can be documented savings that might help in pushing along some of these proposals in an economic sense?
Mm-hmm. Yeah, you mentioned some studies, the Aetna study. You may want to.
Yes, I'm confident in that, that there is a cost savings. There is a body of literature that would support that conclusion, and I'd be happy to provide that to you and your committee for your information.
Yeah, I was particularly struck by the findings in the studies that the good doctor mentioned, in that not only for the person who was suffering from alcoholism, but for his entire family, there was a decrease in medical care costs subsequent to treatment. And I think that was a very important finding there and a very encouraging finding.
We'd be pleased to receive that, because I'm not sure if the general public is aware, but this committee has had Mr. Waxman's bill jointly referred to it. So we have jurisdiction over that whole legislative initiative, and would be pleased to get that type of information, because in addressing this point that we're talking about this morning, it may very well be that we would have an opportunity to make modifications in the ways that you've advocated if we were able to satisfy the majority of the members of this committee that was desirable. My last point comes from my membership on the Veterans Affairs Committee. I've seen studies that talk about the universe of veterans who are serviced in VA hospital facilities as being a universe that has a disproportionate percentage of people with problems of alcohol and drugs. And I'm wondering if either of you are familiar with the VA mode of treatment for that disproportionately large universe, and whether we can learn anything from what they've done. If they're doing anything that's desirable, is there anything that you can suggest that we could, particularly those of us who are on that committee, could be able to direct the VA to do, almost as a learning experience, a demonstration project, case study process? If they have a disproportionately large percentage of those problem cases in their treatment universe, maybe there are things we could learn if we gave them some sense of direction. Are either of you familiar with what the VA does or doesn't do in this area?
I myself, having not worked or trained in a VA hospital, am less familiar with the system that is used there. But I can gather more information for you. I'm specifically thinking of Dr. Mark Schuckett, who is associated with the San Diego Veterans Administration Hospital and is a leading, or is a leader in this field, and has done quite a bit of research and would be intimately familiar with the details that you're asking about.
Thank you.
Right. I am not familiar with the VA approach. They stand in our state as separate from the public system, and we don't license or otherwise monitor the program.
Gentlemen, thank you very much. We appreciate your help this morning.
Thank you.
We're now going to move to our next witness, who has some colleagues with him. We are pleased to welcome to our committee Mr. J. Paul Malloy. He's here in his capacity as General Counsel to Oxford House, Inc. We would note for the record that the committee is very familiar with Mr. Malloy. Mr. Malloy is a former minority counsel to the full Energy and Commerce Committee and distinguished himself in that capacity on many occasions in many different subject matter areas. Mr. Malloy, we're pleased to have you here. We would ask for the record that you introduce your colleagues, and as I stated to the previous panel, Prepared statements will be put into the record in their entirety, and you may feel free to proceed as you see fit. Mr. Malloy.
Thank you, Mr. Chairman. We once again appreciate your generosity in seeking us out and talking about this very important area. Today, I have 3 friends with me who live in Oxford houses. And on my immediate left is Susan DiGiovanni. Next to her is Carlton Brown. And on my far left is Steve Poland.
We welcome you to our committee.
Thank you. Each of these individuals live in different Oxford houses, and I'd like to talk about Oxford House for a minute before we get into some of the issues. It's not only important to me and Steve and Carlton and Susan, but it's something that can be replicated anywhere in the country. I was interested in your remarks concerning Integrity House in Newark, New Jersey. We have 17 Oxford houses here in the Washington area and 1 in Bethlehem, Pennsylvania. Each of the Oxford houses in this area receive an average of 20 applications a week that they can't take care of. The only way that people know about vacancies in Oxford House is through a grapevine of AA meetings and NA meetings. And in December of this last year, for example, the house that Steve lives in had 1 vacancy and 160 people applied. It's clearly a great need for the kind of living situation that Oxford House provides. I think as I sit up here that 13 years ago, 3 important things happened in my life. First, I began a 2.5-year residence in Oxford House. Second, I began a continuous period of recovery from alcoholism. Third, I began a 6-year employment on the minority side of this committee's staff. As I sit here, I think about the first Oxford House manual, which is kind of a book of operations that make all the houses run in a smooth way. Was typed on the typewriters across the hall, of course in off hours, but in 1975, Montgomery County, Maryland closed a halfway house for recovering alcoholics, and they closed it for economic reasons. Several of us living in that house panicked. We knew that if we were to go out on our own again, we probably would return to drinking or using drugs. Fortunately, with the advice and support of a member of Alcoholics Anonymous, we took over the lease on that halfway house and decided to run it democratically as an alcohol and drug-free house for recovering alcoholics and drug addicts. That was the first Oxford House. Most of us in that first Oxford House had been in and out of AA and treatment facilities many times, but we always relapsed into our old addictive ways. The relapse is an interesting phenomenon in the field of alcoholism and drug addiction, and it's really simple to understand why it happens. All of us as human beings are built with mechanisms that tend to forget pain fairly easy. If you ever had a toothache and it really was painful, and then you go to the dentist and the dentist fills the tooth so it doesn't ache anymore, you really forget the pain of that toothache in very short order. For those of us who were addicted to alcohol or drugs, all kinds of bad things happened to us. Violence, broken homes, lost jobs, all kinds of terrible things. But because we're human, we tend to forget those bad things. The body tends to have a system, and the mind tends to have a system where you go on and forget the hardships of the past. Unfortunately, it doesn't work that way with the good feelings. And for those of us who became dependent upon alcohol or drugs, we became dependent because the alcohol or the drugs did something for us, made us feel better, made us more confident, we liked it. I haven't had a drink in 13 years, and I still get a warm feeling when I think about Canadian Club and Budweiser, which happen to be my favorite beverages. What happens is that it's necessary to keep our memories green once we go through a treatment. A treatment facility does 2 things. It first of all detoxifies us, both with respect to alcohol and drugs. There becomes a physical dependence upon that alcohol or drugs. And those terrible shakings that we saw in movies about the alcoholic or the drug addict getting off drugs are there because physically there's a physical withdrawal. The physical withdrawal's over in 7 days. But then begins an education process where the individual has to learn an entirely different lifestyle. In my particular case, I was about 35 when I stopped drinking, but for at least 15 or 20 years before that, alcohol had become very important in my life. And I associated it with all kinds of things. For any of you who have given up smoking, you probably will notice there are still times when you think, gee, I'd like a cigarette, whether it's after a meal or using a telephone. That part of life, alcohol or drugs, becomes part of the life for the addict. And so to get well and not relapse, it's necessary to develop an entirely different lifestyle. And different individuals take different amounts of time. There are some individuals who will have a crisis in their life because of alcohol or drugs. A wife or an employer pushes them into an AA meeting, and from the first AA meeting on, they never have another drink. Others will go through crisis after crisis after crisis and find it very difficult to change a lifestyle so that there is no use of alcohol or drugs. We have nearly 200 people living in Oxford houses in the Washington area, and to date, Oxford House has been totally self-supporting. The funds have been generated from the people who live there. The people who live in the Oxford houses come from a cross-section. The population ranges from people who may have been homeless for years and years and years and have not been productively employed, to lawyers or doctors or Indian chiefs who were productively employed but then lost their jobs because of drinking. Each Oxford House is operated like a fraternity or sorority. It's democratically run. It elects officers. Each 6 months the officers are changed so that there's no bossism that created in the house. For new people to come in, the members of the house sit down and vote on whether or not they will accept the new applicant. If anyone drinks, takes drugs, or doesn't pay their rent, they're thrown out of the house. And that's really the secret of it. It's pretty simple. We don't own any houses and have no desire to own houses. We consider ourselves simply the same as a large family, and we'll go to rent a house that has enough bedrooms. In the men's houses, most of the bedrooms are shared, 2 men to a house. In the women's house, each of the women have a single room. The average size of Oxford House are 10 people per house. Our houses tend to be in the best neighborhoods of the city, whether Chevy Chase, Capitol Hill, Connecticut Avenue, Vauxhall Road, Silver Spring. And we're convinced that what we have is an important supplement to the existing kinds of treatment programs and rehabilitation programs. And we think it's an important supplement because for us, it worked. We were able to stay sober. We were able to take advantage of that treatment because day in and day out we were able to live with other people who were recovering from alcoholism or drug addiction, and day in and day out they were able to reinforce in us the need to change our lifestyle to one of abstinence. In my statement, there is a survey mentioned that John O'Neill conducted for the Department of Labor, which looked at Oxford House as a model. And I won't go through that, but I bring it to your attention to show the varied kind of population that we have in Oxford houses. Mr. Chairman, I don't want to take more time because the most important people here are the people who are living in Oxford houses right at this moment and know a great deal about them, and I want to turn my time over to them. But I do want to thank you and the committee for having us here, and you and our good friend Congressman Madigan, for example, is trying to get a provision in the drug bill that will cause some of these houses to be in Newark, New Jersey and elsewhere. Susan?
Hi, thank you. Good afternoon, Mr. Chairman. My name is Susan DiGiovanni. I've been living in the Oxford House now for a little over 2 years, and the reason why I'm here today is just to share with you what it's really done for me in my life. I went through one treatment center and moved right back home with an aunt and uncle, and I could have everything I wanted, and it was a beautiful atmosphere, and they tried to understand what I was going through. But it didn't work for me because as Paul was saying earlier, I forgot the pain. And I wanted to live like they were living. And I tried going to AA meetings on my own. And it was really hard to just get involved in the program and reach out because I never knew it was okay to ask for help or make mistakes. And I needed more guidance. And I was in a treatment center. It was a long term. It was I was in there for 4 months. And I came out and wasn't being honest with myself. And wanted their love more than anything and wanted to think that I was okay, and I really wasn't, because I was drinking and drugging for 9, 10 years of my life, and I had to change everything, my job. I was a bartender for many years. I had to start all over, and that was okay because I had listened to other people and I thought that I could do it. But I couldn't. I couldn't do it, alone. I then shared with one of my counselors that I had had a drink, and he suggested that I go into another 30-day program. And that's when I started listening because, excuse me, because I knew that it wouldn't work anymore my way. And after the 30-day treatment center, he also suggested that I go into an Oxford house. And I thought there was going to be, bars on the windows and, 6 other women. How can you do it? I mean, I never had 6 other women in my life at one time, and I really didn't think that I was going to make it. And I went for an interview, and I'll never forget my counselor said, Susan, when you get to the house, make it look like you really want to get in there, make it look like you really want to move into this house. And another person from the program came and picked me up from the treatment center I was in. I went for the interview, and they said to me, would you like to see the house? And there was no expression on my face at all. I mean, I might as well have said, I'll just leave that to your imagination. But, I mean, I was just not, into moving into this house at all. Even after I met the people, even after I saw the house was beautiful, I was scared. And I really did want to go back home. And I pushed myself to move into this Oxford house. I really did. And the first 3 weeks, I still went home to my aunt's every night and slept. I would go and do my chores and be at the meeting, but I would go and I would sleep. And it took some time to feel at home, to make that place my home, the Oxford house. But today it is my home. Those girls did a lot for me. My behavior has changed. My attitude has changed. I really have a lot of hope. I think that all people, all addicts, all alcoholics, need a follow-up. You can't change in 30 days, because we don't just have to change one thing that we do. We have to change a lot of things, and it doesn't happen overnight. And it's a whole new way of life, like the gentleman was saying before about diabetes. It doesn't go away. There's no cure. You have to live with it every day. Well, so do we. And it takes a long time to accept and give in, And as I was growing up, I was taught never to give up, And that's another reason why we fight it till the end, to the pain, till some of us die. Because I was taught when I was young never to give up. I'm not powerless. I am not. Today I can admit that and feel great about it and really feel good. The house, like I said, there's just not enough that I can say about this house, what it's done for me. It's just a positive environment, and, it's helped me go through rough times in my life, while I'm sober, to change more than anything, because if you don't change, you will go back to using. And I had some, older sisters that could teach me, how to change and get through things, and it was going to be okay. Thank you.
Thank you. I think what we'll do is take a brief recess for about 10 minutes. We have a vote that's now pending on the floor. We'll be back in about 10 or 15 minutes, and we'll hear from our last 2 witnesses. The committee stands in recess.
While this hearing on health insurance and drug and alcohol treatment recesses, we'll also take a short break to bring you some schedule information and have more of this hearing in a few moments. Good morning from Washington. Tune in tomorrow morning when our Communications Today segment will feature a speech by newsman Walter Cronkite. He spoke recently at Brown University in Providence, Rhode Island, to the National Association of College Broadcasters. Again, that's journalist Walter Cronkite, Saturday morning at 11 o'clock Eastern Time, 8 on the West Coast. Today's schedule continues after this hearing on health insurance and drug and alcohol treatment with today's Journalist Roundtable. Our guests were Christopher Hitchens, columnist for The Nation, and Vladislav Plevchinsky, managing editor of The American Spectator, and that airs at 10 minutes past 1 Eastern Time. At 2:40 p.m. Eastern Time, 11:40 a.m. on the West Coast, it's a House Small Business Subcommittee hearing on cosmetic safety. Witnesses included representatives of the industry as well as governmental regulatory agencies. At 6:30 p.m. Eastern Time, 3:30 Pacific, we'll spend 90 minutes on a live viewer call-in program with author John Tratner, who's written about the presidential transition. And just after 8 p.m. Eastern Time, it's today's special State Department news briefing. That's our schedule over the next few hours. Thanks for being with us.
The process of selecting a new leader of the Senate has begun. Join C-SPAN for interviews with the 3 candidates for the Senate majority position and find out about the politics behind the scene from people in the know. Sunday, beginning at 8 p.m. Eastern, 5 p.m. Pacific Time on C-SPAN.
Make the most of your C-SPAN viewing with the C-SPAN Update. It's the weekly newspaper of the C-SPAN network that helps you track the public affairs events our cameras record. Interested in C-SPAN's coverage of the National Press Club? The C-SPAN Update lets you know who's speaking in advance. Want to learn more about the judicial system? Regular features in the C-SPAN Update are a perfect complement to C-SPAN's America and the Courts series. Or how about a behind-the-scenes look at the new administration coming to the White House? Follow the presidential transition on C-SPAN and on the pages of the C-SPAN Update. Public affairs programming that matters to you. Find out about it in the C-SPAN Update. Call 1-800-346-8800 for a 1-year subscription. You'll get 50 issues for just $24. If you order an update subscription now, we'll also send you Justice for All, a guide to the Supreme Court of the United States. Its glossary of legal terms and explanation of court proceedings is useful for your viewing of C-SPAN's Supreme Court coverage. The inner workings of the third branch of government at your fingertips. Call 1-800-346-8800 and we'll send you 50 issues of the C-SPAN Update and Justice for All for only $24. Call today.
At least 15 hours each week, you can become a player in the political thought process by joining the discussion with journalists, elected officials, and policymakers. The C-SPAN viewer call-in program gives you the chance to talk with the people who are shaping the issues and making the headlines. Weekdays at 8 a.m. Eastern Time, that's 5 a.m. in the West, and again at 6:30 p.m. in the East, 3:30 p.m. Pacific Time.
C-SPAN is the cable industry's public affairs network. Since 1979, C-SPAN has provided nationwide audiences an insider's look at the democratic process. If you have a comment about our network, please write to us. Our address is C-SPAN, 444 North Capitol Street, Northwest, Suite number 412, Washington, D.C., and the zip code is 20001.
In many areas of medicine and public health, we're making excellent progress: hypertensive screening, organ transplantation, cancer detection and control, and so on. But in many other areas, we seem to be running in place, if not actually falling behind.
A speech by Surgeon General C. Everett Koop before the National Foundation for Infectious Diseases. Sunday, beginning at noon Eastern, 9 a.m. Pacific Time.
Up next, we return to our coverage of a hearing on health insurance and drug and alcohol treatment.
It's amazing.
Sir, we'd be pleased to hear from you.
Yes, my name is Carlton Brown. One of the first things I'd like to say is that as far as the Oxford House is concerned, is that coming out of treatment, I felt like that time that had lapsed, that I went into treatment for those 30 days, was just not enough for me to go back and to my quote-unquote normal way of life. And the Oxford House is a very supportive place for me. And I've gotten a lot from it. I've gotten back into the mainstream of life through being in an Oxford House. I think that that the type of support that I get in the Oxford House has to do with me being able to identify and other people being able to identify with my problem as a drug addict. And I don't know, I just find that, you know, I don't think that without an Oxford House, without living in the Oxford House, and I've been there now for about a year and a half, I don't think that without the Oxford House I would have been able to have come this far and be kind of a productive member of society again, you know. I don't know that, you know, that the thing that really sticks with me is the fact that, you know, the support of the Oxford House, it's allowed me to like really gain back my responsibilities that I let go. It's allowed me to hold a job and to work it. It's allowed me not to learn how not to manipulate and try to get over on people that were directly involved in my life during my addiction. It's just really afforded me a lot of things, and basically I'm saying that it's afforded me my life back. You know, after practicing and using drugs for about 17 to 20 years, it's really important to me. I heard the gentleman speaking earlier about the 30% of people who make it that go through rehabs, and I feel like that percentage is better than no percent at all. You know, and for me that's very important because right now, as it stands, I am one of those 30%, and I'm really very appreciative of the Oxford organization. It's just a great support system. You know, I really can't. You know, it's like a family, and all the houses in the city we are you know, basically in touch with one another. And we have a common bond, you know, to kind of grasp life on life's terms, and there's a lot of love there. It kind of teaches you how to love people and help people out without expecting things in return. It's kind of teaching me how to deal with people and deal with different personalities without trying to get the negative or trying to I don't know, to more or less get the positive out of the situation as opposed to the negative, you know. It's kind of funny because, you know, a lot of times we have Oxford House meetings or organization meetings, and basically they're held basically the same way these are, very organized, and it's amazing that that a bunch of addicts and alcoholics can get together and do something and be productive with it. You know, the houses that we have established, I would say out of those, well, I'll just speak from my personal house. In our house, I think since I've been there with the guys that were there when I came in, I think there's been maybe anywhere from 2 to 5% of those who came in the Oxford House have actually not, really gone through with the program that they came in on. And I don't know, it's just a really supportive way of life for me, and I really can't say enough about it. I don't know, I just love the guys that's in there, and we have a very good understanding. We look out for each other. I don't know, there's just like so many things I wanted to say about it, and now I can't really think of what they were, but it's just a great support system for me, and I think that it's very important and instrumental to me coming out of the rehab, being an individual that would have gone to any lengths to keep and stay clean, keep my sobriety and stay clean, and kind of like become a productive member of society again, which I very much feel I am as of today. Thank you.
Thank you. Sir?
Hi, Mr. Chairman. My name is Steve Poland. I'm a recovering alcoholic and drug addict. I'm one of these people who've been well educated. I have a BA, I've been to graduate school, I'm a law school graduate. I've also been to prison. I've also lived on my own, had my own apartment for several years on Capitol Hill. And now I'm rebuilding my life and putting things back in order and becoming productive and responsible again, mainly because of my participation in 12-step programs and because of my residency in Oxford houses. One thing I found out after my release from prison and release from the halfway house and upon entering the workforce again was I had never worked before or lived before clean and sober. My entire adult life I have been using drugs and alcohol, and of course this was something that entered into my work habits and my living habits and just the way I conducted my life. It ends up when you're consumed with a cocaine addiction or an alcohol addiction that you forget about taking care of things that need to be taken care of. You worry about the shortcut. The drive to excel vanishes. You're only concerned about getting by, and you're only concerned about getting more drugs and alcohol, because that's what your life revolves around. You start running into employment problems. I worked for the government for 9.5 years, Mr. Chairman, and at the end of my employment I had a negative leave balance because of my disease. And I was incapable of getting to work on time. I was constantly taking days off of work, only because I was in no shape to go into work. Upon residency in the Oxford House, which was suggested to me, I didn't have much money, and I needed a safe place to live, because the life of drugs and alcohol is something I did not want to go back to. The Oxford houses have just a few simple rules. There is no drinking or using. If it's found out that you have, you will be automatically kicked out of the house. Everybody is assigned a chore, and it's expected, you're expected to do it. And you're expected to pay your rent, and you're expected to pay your rent on time. If there's one thing in my experience in living in the Oxford House that will get you in trouble faster than anything other than drinking or using, is not paying your rent. Because one thing that we all have in common is that we used to be financially irresponsible. And the rent is cheap, and it's affordable, and the demands are not great. And if there's a problem with the rent, the members of the house are willing to work with you to work something out. But this will definitely get you in trouble. It's a reflection of attitude. Everything about Oxford House, everything about recovery is about attitude, and that's about what kind of willingness you're willing to display. How far are you willing to go to get this thing called recovery, to start turning your life around, to start learning how to function with everybody else you know, in the real world and play by the rules of the real world, because one thing addicts and alcoholics have in common is that, you know, the rules do not apply to them. In Oxford House, as Carlton and Susan were saying, you know, there's a great support system, and this support system goes to the extent that people take a look at your attitudes in there. You know, are you willing to do things the Oxford House way, or do you still want to do things your own way? Because one thing addicts and alcoholics love to do is do things their own way, and this is one thing that will get you in trouble faster than anything else. I used to be like that, and I'm finding out it's a lot easier to get along in life just to go along with the flow instead of bucking it, instead of reinventing the wheel. As I was saying, you know, you learn to trust each other in Oxford houses. Addicts and alcoholics don't trust anybody, and nobody trusts them, you know, for very obvious reasons. Because we have a system of electing officers, and there are 2 or 3 positions that carry financial responsibility. The treasurer, the comptroller, coordinator. You're given money. You know, you're trusted with it. You can sign for checks. You know, some houses have bank balances of several $1,000s now. You know, it's a matter of trust. I mean, and that goes a long way in getting you, re-assimilating back into the real life. I mean, people trust me today, which is something that they didn't do 5, 6 years ago. Because, I mean, I wouldn't trust me 5 or 6 years ago because I was incapable of it. I was incapable of being truthful. I was incapable of a lot of things. But because of what Oxford House has given me, you know, a safe place. One thing about living with a group of recovering alcoholics and addicts is that you can't pull one over on them. Everybody has lived that lie before, has lived that con before, and you know, you learn to be truthful in there, or you pay the consequences through a pull-up, you know, which is something that, if it happens at a house meeting, is what we call being placed on the hot seat, and you know, it can be a very uncomfortable experience. People in there are willing to help you, but you got to be willing to help yourself first. I mean, we have there, you know, as Paul and everybody else has said here today, there's a great demand for Oxford houses. We had 2 vacancies, which we interviewed for Sunday night, and we had 8 applicants. Remember one time last fall, we had 1 vacancy and we had 20 people show up for an interview. I mean, it's unfair that we can't take all 20, but we can only take 1. And it's a very tough criteria because, you know, of course we want to accept somebody who is going to work, who's going to fit in, but, you know, we don't know about these things. You know, just as the witnesses you had before were talking about the success and failure rates of recovery programs, the same thing holds true for Oxford House. But I do see something that works in Oxford House that, you know, maybe does not work in doing it on your own or coming right out of treatment, and that you have a place to take these tools, to take these lessons out of treatment and put them into application without having to be pressured by the real world. Well, I mean, we're pressured, but there are people in there who are willing to help you work through your hard times. It takes a lot of willingness to do this because it means changing everything that you're familiar with, your thought patterns, your attitudes. It means changing your friends, changing places you used to go, and just the way you used to do things. One thing that I found, that at least in our house, they used to live, because that will mean that they will end up using or drinking again. It's either because of the part of town from where they're from, or because whoever they lived with enabled them, or because of, you know, there is a family member or somebody else close to them that is still using drugs or alcohol. The Oxford House, you know, gives you time to take that, either coming right out of recovery, or treatment, you know, to get that strength again. And one of the great things about the Oxford House, unlike some of the halfway houses that some of these treatment centers are associated with, there is no time limitation. You can stay at the house as long as you follow these few simple rules that we have, for as long or as short as you want. And if somebody moves in and they think about moving out right afterwards, the House members will let them know what they think about, whether they're ready or not. You can get a sense of where you're at in your recovery and how far you've progressed by the other House members. I've lived in an Oxford house for about 20 months now, and you know, it's something that's needed. I mean, it's cost effective, it's self-supporting, and one of the great things about self-supporting is that, you know, we do this ourselves. You know, we take the responsibility of meeting our bills, of paying the rent on time, paying the bills on time, and doing things responsibly, which is something that most of us who lived in in these houses have never done before. Before entering Oxford houses or before entering 12-step programs and trying to change their life around. And I hope this committee and I hope the Congress seriously sees the need for this type of housing and for this type of help in giving an opportunity to those who want to change their lives to be able to do it. Thank you.
Thank you very much to all of our witnesses, and particularly to Paul for helping us to get the opportunity to listen to you as a part of our process of trying to gather information to make appropriate policy changes. Paul, I assume that the legal structure for this whole entity, the system of houses, is a nonprofit corporation?
That's right. There's an umbrella. Oxford House, Inc. is an umbrella nonprofit Delaware corporation, 501c3, and I guess as we go down the road and we decide to collect money from donors so as to set up a revolving fund, it becomes significant that we're a 501c3. But to date, Oxford House Inc.'s treasury, I think, hit a high point at $220 once.
Has anyone accumulated any data so as to be able to, for example, answer some fundamental questions? What's the average length of stay of people in the facilities?
Yes, that survey I referred to in my statement includes that. The average length of stay is just under 1 year. Okay. About 5% of the people in Oxford House have been there over 5 years, so it's varied and it's kept flexible.
The survey deal with the question of recidivism, people that have stayed, left, and then stayed clean?
Within the last year, we have begun to set up a process to have a long longitudinal study on that. What we rely on when we look back is people's memories. Is so-and-so still sober and so-and-so still straight? We think it's a high percentage. We can't be sure.
One of the things that's in the bill that is being debated today on the House floor is a provision dealing with capital availability for facilities such as this, nonprofit and publicly operated residential treatment facilities. Now, I'm not sure if you would be defined as a residential treatment facility for not only purposes of this bill, but also for purposes of third-party payment systems. Have you any thoughts as to what the perception would be as to whether you are a treatment facility?
Well, number one, we would not be recognized as a treatment facility and don't want to be for zoning purposes usually. If one is a treatment facility, it becomes a very difficult problem to go through the hurdles of zoning restrictions of having a group house. I'm optimistic that as the bill gets refined on the House floor, it will include a category that will set up a revolving fund in each state so that any group of 5 or 6 recovering addicts or alcoholics can get a loan from the revolving fund to start a house. The only barrier in starting up these houses is the first month's rent and the security deposit. And we think that the revolving fund concept takes care of that, and that it can be expanded almost as far as the eye can see, because if there's rental property available in any city, all it takes is a group of recovering people who want to follow a simple rule that you throw people out if they drink or take drugs and if they don't pay their rent. But otherwise they could affiliate with Oxford House, or there could be dozens of other organizations like Oxford House created. We don't have any claim, nor do we want to be a monopoly, But we do think that it makes sense for recovering people to get together, rent a house, and live in an alcohol and drug-free environment so as to improve this terrible relapse rate. There's no reason that the first time through that a person can't stay sober the rest of the time.
With regard to the question about third-party insurance payments, do you foresee, or do you even think it's desirable, to try to define what it is that you do in the facilities so as to be able to qualify?
I think that third-party insurance payments probably don't fit the Oxford House model. However, if I was an insurance company interested in keeping the health care costs low, I would invest some money into these kinds of revolving funds so as to encourage this kind of residential housing, because overall it would then lower the cost of health insurance coverage. And what little I know about the health insurance industry, I see similarities to the way railroads used to be before you pushed through the Staggers Act and deregulated railroads. So I'm not sure what kind of, I've heard, for example, people that say, well, health insurance companies don't care because they can just pass the cost on to the people who have to buy the insurance. I'm sure that's not correct. I'm sure that there's a big incentive for health insurance carriers to have low cost for their members so that they can improve their market share. The easiest way for health insurance companies to get low cost when it comes to alcohol and drug addiction treatment is to figure out some way to finance these long-term residential facilities so that people can live in an alcohol and drug-free environment after they have gone through the treatment facility. The treatment facility really just gets the person detoxified and then gets their attention. There's a lot of help needed after that, and that length of time depends on the individual. Some people may stay 2 months, some people may stay 10 years.
Let me ask the three witnesses if they have any thoughts as any particular distinctions that flow from one being an alcohol abuser versus a traditional drug narcotic abuser. Do you, in your experience, note differences in the two types of abusers that result or would result in the need for different approaches, or are the similarities, the problems, the addictions, just parallel on all fours to the point that there isn't a need for different modalities or different sensitivities in dealing with the problems?
My personal opinion is that it's all the same. It doesn't matter what it is. If you're abusing it, you know, it's a drug is a drug is a drug. Coffee, cigarettes, I mean, the list goes on. Gambling, sex, you know, anything at all.
Anybody else have any observations?
I'd only say that I agree with Susan. I really don't think there's much difference. I mean, other than how one goes about getting alcohol versus how one goes about getting drugs, you know, that's the difference. Other than that, I mean, the behavior is the same, the denial is the same, the attitude is the same, the irresponsibility is the same. I mean, once you're dependent upon it, and once you're powerless over it, and once it starts running your life, the end result is the same.
Do you agree with that, Mr. Brown?
Yes, I do. The only other thing I'd have to add is that coming through the rehabilitation facility, it would be a difference in detoxification. That's about it.
Okay. Let me express, if there were, Chairman.
Yes, I apologize. I couldn't come back for the Mr. Brown's and Mr. Poland's statements because they're trying to save one of my national parks from an unwarranted assault, and so I had to stay there. Actually, I have some questions. First of all, I congratulate you for your fine testimony, the two I heard, and I'm sure the other two are equally good. Let me ask two questions which are totally unrelated, but yet we do have to deal with them in this Congress or early next Congress. We have bills before us, or at least assigned to our committee, of two kinds. One is to make labels, warning labels on alcohol. That's a bill that comes from us on the Senate side and also from this House side, to require labels on alcohol, warning labels, similar to the ones on tobacco. And the other bill is one that I sponsored last year to ask the FCC to check on advertising. To what extent should alcohol be allowed to be advertised? Do you have any thoughts on either of those? Would either of them or both be deterrents, do you think, to having people get involved in alcohol? These don't relate to drug. This is alcohol only. Do you have any thoughts, any of the four of you, on those? Are we overreacting or underreacting on these areas? Boland, do you think we should ban the advertising, for example? Do you think we should put warning labels on?
Well, I really don't know what kind of warning labels you're talking about. I don't know. I mean, the problem I see is that it's legal.
Labels such as this can be addictive, or that this in the excess can cause social problems. That type of learning, similar to ones we have on tobacco.
I really don't have any opinion. No.
I do. I think, you know, the labels, they're going to try it either way, you know, but the advertising to me is something that's real big because, you know, if you see it and they make it look good, you want it, you know, and that goes with anything, whether it's a toy or a dress or whoever's modeling it or whoever uses that kind of shampoo, I want to look like her, you know. The advertising, yeah, I would definitely say that, you know, plays a big part of it. You know, if you drink Budweiser, you're going to be John Wayne, you know, yeah, I believe that, you know. You know, like I said, the warning labels, it's on cigarettes, and yet I feel today that things are turning around in that area too, that people are, you know, trying to quit smoking too. Thanks.
Congressman, back when I was a practicing alcoholic, I worked on the Senate staff, and one of the tasks I had, I think in 1968, was to deal with the cigarette labeling.
With Senator Moss?
Yes. And I was on the minority side at the time, and we had to figure out what would be the least damaging to people we were concerned about of the tobacco industries. And the original label said cigarette smoking may be hazardous to your health. And as proposed, it was going to be cigarette smoking may be dangerous to your health. And the senators that were there at that time in the executive room went out and did a survey among the secretaries and others out in the outside area to see how many knew the word hazardous and how many knew the word dangerous. And the word hazardous was chosen because it had less recognition, and I'm not sure whether that's good or bad. At the time, I thought that was a very silly sort of thing to do, but clearly 25 years later, those kinds of labels and the kinds of public education that's taken place means that a lot fewer people smoke today than did in 1968.
I appreciate the Chairman's indulging me in a question, because I've been besieged by numbers to co-sponsor the one, which I've not done, and on the labeling. I've not been convinced labeling does much good, but just wanted to hear your view on that. I do think a ban on advertising or restriction on advertising might have more direct impact, and that was my own. That's why I wanted to ask the question. Thank the Chairman.
Thank you very much. Again, let me express the appreciation of the committee to the panel, and we look forward to working with you in the future. Thank you very much.
Thank you, Mr. Chairman.
We'll now proceed to our last panel, which is made up of Dr. Robert Rosen, the Senior Associate of the Washington Business Group on Health, Mr. Thomas Delaney, Jr., Executive Director of the Association of Labor Management Administrators and Consultants on Alcoholism, and Ms. Patricia Amosita, Director of the Utilization Management Division of Blue Cross Blue Shield Association. Gentlemen, lady, we appreciate your being here today. We will include in the record your statement in its entirety, and Dr. Rosen, we'd be pleased to hear from you.
It's a pleasure to appear before you today. I wear two hats. One is as a clinical psychologist and assistant professor of psychiatry at George Washington University School of Medicine, and also as a senior associate at the Washington Business Group on Health. The WBGH is a national organization which represents the health policy and economic concerns of major employers, about 200 large Fortune 500 companies. And over the past 15 years, we have been examining and monitoring the mental health and substance abuse benefits, needs, and concerns of major companies. And from both of those perspectives, my remarks come today. I think substance abuse presents one of the most difficult challenges to society. It's an emotionally charged topic, one that evokes strong prejudices and many myths and misunderstandings that plays a major role in how we as a society and our institutions deal or don't deal with the problem directly. And I think the comment about the hazardous label is an example of that kind of irony. No matter how you look at the issue, the numbers are great and the costs are staggering. Alcohol is clearly the most widely used intoxicant. About 14 to 18% of American workers abuse alcohol or drugs or both, and that comes to about 17 to 21 million impaired workers. And this doesn't include the family members and retirees. I think most of the attention has been spent on the seriously impaired alcoholic. However, the bulk of drug abuse and alcohol abusing people are in the working age population between 21 and 55. Many of them are light to moderate abusing drinkers or drug takers, and in fact, as you mentioned in your initial remarks, 85% of them don't even receive treatment. Given that employment is the principal vehicle through which people receive health care to begin with, I think that the worksite is clearly an important place to start. First point I'd like to make is the economics of substance abuse, because I think we're starting to find out now in 1988 the cost of doing nothing about the problem. Business pays much of the tab, about $71 billion in lost productivity and employment. Now, they may not always pay all the costs for treatment, but they almost always pay the cost of the consequences of substance abuse on productivity. And we're just starting to learn about the cost of those productivity consequences to the bottom line and to the overall competitiveness of the country. It's business. The costs are always underestimated, generally because of the denial component, the chronicity of the illness, the progressive nature, and the hidden nature of the symptoms, both in drug abuse, other addictions, and alcoholism, which makes it all the more difficult for companies and unions to get a handle on how much they're really spending by not doing a whole lot. We have some important statistics, though. First of all, we know that as many as 20 to 50% of all acute care hospital beds are occupied by patients whose health problems are in some way related to substance abuse. Companies are collecting more and more data. In fact, one Massachusetts employer projected that about 8 to 10% of their health costs would be related to substance abuse, but when they got a hold of the data, it was some 25 to 30% of their costs were related to substance abuse. Firestone Tire and Rubber reported that, for example, drug-abusing employees were almost 4 times as likely to be involved in an accident on the job, 2.5 times as likely to be absent from work for more than a week. Drug users were also 5 times as likely to file worker compensation claims. So the statistics on its relationship to productivity are pretty clear. And most concerning, I think, are recent court decisions that signal a trend that employers may become liable for substance abusing employees when they allow their employees to drink during company functions. And there are a couple cases on the courts now that seem to be leading in that direction. Deteriorating job performance is clearly the first sign in the problem, and I think that's where we should look first. These are the economics. What are some of the barriers to the problem? Well, first of all, in this country, we have consistently discriminated against mental health and substance abuse, consistently discriminated in our benefits policies and programs, both in government and in the private sector and unions. I think this is a reflection of the societal emphasis of the body over the mind, and I think that we're just starting to appreciate the importance of mental health and the mind and relationships as it relates to illness. And I think substance abuse fits into that prejudice. There is still social stigma, despite the fact that we have made progress in this area. This affects how often people use benefits, how often they go to employee counseling programs, and what kinds of benefits companies offer. There are still negative attitudes among management that still get in the way of effective treatment. There are problems when people come back to work after benefits. Unsupportive or ill-prepared companies not ready to receive the substance abusing employee get in the way of people taking treatment. As I mentioned, we consistently underestimate the prevalence of the costs, and the symptoms are often hidden. There are problems in the marketplace, too, that interfere with companies offering substance abuse. First of all is that there's considerable fighting over reimbursement. who should provide the treatment, who should get paid for the treatment. The fact that there are 200 different mental health treatments available makes it very difficult for business to conclude that the mental health and substance abuse professions know what they're doing. And in fact, the discussions earlier about tailoring treatments to problems is a step in the right direction, but it clearly has gotten in the way of businesses making progress in this area. Many are not convinced that treatment is cost-effective. Abuses by psychiatric hospitals and residential treatments have gotten in the way as well. Clearly, most surveys show that employers typically will fund inpatient physical health insurance at much greater rates than for mental health insurance. However, I think a greater barrier is the discrimination against outplacement treatment. Clearly, the data shows, based on an Office of Technology assessment study, that any treatment is better than no treatment. However, we're not quite sure what treatment is most effective. And in fact, intensive outpatient treatments with strong aftercare and strong family involvement can be equally as effective as inpatient treatments. And that data and research is slowly getting into the benefits offices of America's companies, and they're starting to redesign their benefits accordingly. And I'll talk a little bit about some examples there. Unions, too, offer health insurance. They, too, have discriminated against substance abuse. They have offered employee counseling programs, but again, macho attitudes coupled with the popularity of social drinking in many union environments have gotten in the way of people accessing treatment as much as they could. Small companies have done less well in offering health benefits in general, and particularly mental health benefits. The cost clearly is staggering and is of great concern to them. This is a group that I'm very much concerned about, mainly because most of the new jobs are occurring in the small business marketplace. As I mentioned, many of these small companies offer limited substance abuse, if at all. And then another problem, as was mentioned earlier, are this 37 million uninsured Americans, many of which are working but do not receive any health benefits at all, and I think we need to address that concern. Let me talk just a moment about the current state of affairs in substance abuse. I think the issue has got to be examined in a decade of escalating health care costs. The average company spends approximately $2,000 per employee on health care costs, and clearly substance abuse claims account for a growing percentage of that cost. In fact, some suggest that the mental health and substance abuse benefit is the fastest growing component. For a variety of reasons, some of which that the benefit is made more available. Others suggest that younger people are more receptive to mental health and substance abuse treatment and therefore more likely to use that benefit. Employers have traditionally not been very good consumers of health care in particular, and particularly substance abuse and mental health treatment. There are generally three responses by employers. One response group of employers in the face of escalating substance abuse costs is to curtail the benefit, to cut it out, to reduce it, to make it less accessible to the employees. And a large, significant number of employers have moved in that direction. That's a concern to me. A second, more progressive group have viewed these increased costs as both an indication of a growing substance abuse problem and also a management problem that they've got to deal with. And so therefore they've employed various kinds of techniques, case management, pre-admission certification, pursuing less restrictive, less costly treatments like outpatient benefits and the like to manage the problem more effectively. And then the third group of employers, and by and large the largest group, sits somewhere in between. And I think there needs to be a lot of education with them. Benefits design is clearly the answer, I think, and the first step in the issue. I found a 1985 Bureau of Labor Statistics survey that surveyed 1,325 firms and indicated that 68% of all participants had some coverage for the treatment of alcoholism. This had increased from 38% to 68% between 1981 and 1985, and 61% of them had treatments for drug abuse. However, clearly the benefit focuses primarily on inpatient residential 28-day care, and the data seems to suggest that we can provide more of a less restrictive benefit to more people at a cheaper price and get more for our money's worth in terms of private insurance. I mentioned the Office of Technology Assessment study. There are treatment alternatives, however, and I think this suggests that the definition of the substance abuse benefit is changing. 10 years ago, the benefit was a 28-day inpatient residential treatment setting. However, today, companies have gotten much more active as purchasers of health care, and particularly substance abuse care, and they're exploring all new kinds of ways. Health maintenance organizations, preferred provider organizations, and specifically with substance abuse, managed care. Just like to talk one moment about that. Managed care gets the employer very much actively involved in providing the service. They review utilization. They're involved in contracting with hospitals and residential care facilities. They review the provider behavior. They look for second and third opinions for the benefits. And they also play an active role in getting the person both in treatment and getting them back to the workplace after treatment. With respect to getting them in treatment, there's been a growth in employee assistance programs. There are now approximately 10,000 of them in the country to date. These programs primarily try to identify the alcohol and drug abusing symptoms early on in the process, and then to get these people into treatment. Clearly, my recommendation would be to get these employee counseling program capabilities in every organization in America, because I think that alcoholism and drug abuse is clearly a disease that can be in part prevented. We need a tremendous amount of education and prevention and awareness activities, and I think the employee counseling movement has moved business in that direction. Healthcare cost management, again, is the primary objective of any EAP. Digital Equipment Company offers 38 employee counseling programs around the country. New England Telephone offers a day treatment program for their alcoholics at the company premises rather than farming them out to residential treatment facilities. They find that it's as effective, and also it saves them about, I guess it's about a quarter of the price. Do these programs work? Companies are finding, yes, indeed, they work. And I'd like to finish my comments with a recent case example that we came across from General Motors about their experience with substance abuse last year. In 1985, substance abuse treatment cost General Motors $60 million. They examined their costs specifically, and they discovered several things. One, large numbers of people had repeated drug abuse treatment, the revolving door syndrome, and they needed to get a handle on that. Secondly is that many of them were not receiving post-discharge care. Thirdly, there were wide variations in the costs of services and the types of services, and that many residential treatment service programs were using canned programs, and that the costs were dramatically different across the programs. So what they did was they separated the substance abuse from the mental health and health care benefits. They developed some uniform criteria to measure the substance abuse community, and they started to fund a day treatment program that was less restrictive than the residential care program. 4 conclusions. One is that I think we need to provide greater access to quality, cost-efficient substance abuse care with an emphasis on outpatient patient treatment, with a strong emphasis on aftercare and family involvement. Every organization, large and small, public and private, should have some capability of an employee counseling program to identify symptoms early. We should invest a whole lot more money in prevention and education in addition to treatment. And then finally, the detection and drug testing issue should be put in the context, I think, of rehabilitation, and that it can't stand alone. Thank you.
Thank you very much. Delaney?
Thank you, Chairman Florio, Congressman Nielsen. It's a pleasure to be here this afternoon before you. I represent ALMACA, the Association of Labor Management Administrators and Consultants on Alcoholism. We are a membership organization of approximately 6,000 members who provide employee assistance services through management and labor at the work site. I'm not only representing the organization generally, but specifically today representing the chairman of our Public Policy Committee, Mr. Riley Regan, who is the chairperson or the director of the New Jersey Division of Alcoholism, and he would have liked to have joined you today, Congressman, except he was giving a keynote speech in Asbury Park on a conference on compulsive gambling, but he brings his greetings. EAPs are work-based programs designed to help people with drug and alcoholism problems. In 1981, ALMACA, the AFL-CIO, the National Council on Alcoholism, and the Occupational Program Consultants Association of America adopted standards for employee assistance programs. And one of these standards was that there needed to be, in an effective occupational alcoholism or drug abuse program, adequate provision for health insurance coverage for these diseases. And it was included in those standards, and those standards are still in effect today. Now, why did we feel that organizations that have a occupational alcoholism program need to have health insurance? Wouldn't that be wouldn't the workers be able to just cure themselves by ceasing the use of drugs or alcohol on their own, or by participating in self-help groups such as Narcotics Anonymous or Alcoholics Anonymous, which have been mentioned several times today? First of all, if people could simply break their addictions on their own, we would have a lot less alcoholism or drug abuse. These are painful diseases, and people who are suffering from them want to stop their suffering. They have often promised themselves hundreds or even thousands of times they will stop using the addictive substance. Cruelly, however, they are not able to stop on their own because that's the nature of addictions. A number of people are able to put their alcoholism or drug addiction into remission by directly involving themselves with Alcoholics Anonymous or Narcotics Anonymous or other self-help groups. Almost all addicted people need to commit themselves to a lifelong involvement in these programs on a one-day-at-a-time basis to guard against relapse. Based on the experience that EAPs have had in assisting addicted people, we feel that workers should be urged to go to self-help groups immediately. However, we know that many of addicted persons either have medical complications from the addiction, or they need intensive intervention and redirection in their lives that can only come with formal treatment. All such treatment must include the component of familiarizing the person with AA or NA so that they can utilize these to maintain the substance-free life that the treatment introduces them to. So, in order for an EAP to do its job, it must be able to refer workers to the appropriate treatment for alcoholism or drug addiction. If a person does not have the health insurance for treatment, this presents a serious barrier to the effectiveness of the employee assistance program and to the recovery goal for the worker. If an employee or a union have recognized the need for an EAP, wouldn't they automatically insist and receive adequate coverage for the treatment of addictions from their insurance carriers? After all, isn't the insurance just a commercial product available in the free marketplace, and the consumer can meet their needs by purchasing the desired product? Well, we feel that our experience has been that there are three barriers to this. First is the general denial and stigma attached to addictive diseases. Secondly, that insurance coverage for only sporadic levels of addiction treatment from among the range of levels of care that are needed to treat these diseases. And thirdly, the bias of the health insurance industry to cover only physician-supervised medical care as opposed to the spectrum of health care services available from all health care disciplines. In the late 1970s, the Blue Cross Plan of Maryland added a comprehensive treatment component to its product line and aggressively marketed it to group insurance purchasers in Maryland. It was a well-designed product that would provide coverage for alcoholism and drug abuse. After several years of aggressive marketing, the product just did not sell. The conclusion of this experience was that employees and benefits administrators and top management of business and labor did not recognize the extent of alcoholism and drug abuse, or they feel it just can't happen to us. Just like individual addicts, these groups deny the existence of addictive diseases among their members. Almaca members from organized labor have often noted that their brothers and sisters in the union movement will opt for dental or podiatry coverage before their coverage for addictions. And as some of the other witnesses have pointed out, if we are going to get a handle on the seemingly ever-increasing bill for health care, we're going to have to intervene with the addict so that his or other health care problems do not worsen. The consumer needs this type of protection, and society denial and stigmatizing of addictions is preventing him or her from getting it. The second barrier to adequate health insurance coverage for alcoholism and drug addiction is the lack of comprehensive coverage. Ironically, the tendency of health insurance industry to provide coverage for only the more acute conditions or more intensive therapy has the effect of driving up the cost of treatment. The insurance industry seems to be more comfortable paying the cost of treatment if you have a hospital gown on, or if you're not allowed to continue to function at your place of employment, or in your family role. Not only is this a barrier to women obtaining treatment because of their child care responsibilities, but it is also a barrier to workers because the employers would prefer them to work part-time and attend outpatient evening treatment and continue to work. And I want to add that many of the people could do that. Some of our members have had good experience recently in arranging for evening treatment so that the employee could continue to work and receive treatment. Because the health insurance policies often only cover inpatient treatment, EAP practitioners are often forced to recommend to workers that they admit themselves to a more intensive program than is needed. The choice is often between the worker having to be admitted to a 28-day inpatient rehabilitation program or no formal treatment at all. More recently, some benefit plan redesigns that are supposed to reduce costs have made it worse by insisting that a person go through an acute care facility in order to be eligible eventually for rehabilitation. When the choice is between no treatment or an inpatient 28-day rehabilitation, it's really no choice. If the addict wants help, he will opt for the 28 days. This will drive the figures up for the total cost of treating alcoholism and drug addiction, give rise to cries to eliminate all coverage in order to reduce the costs, and just lead to a bigger addiction problem for business and labor as well as for the whole country. The third problem that EAPs have experienced in obtaining adequate health insurance coverage for alcoholism and drug addiction is historically the health insurance industry covers only medically supervised services and not the broader and often more appropriate spectrum of health care services. In the addiction field, this often happens because the insurance industry has failed to keep up with the progress that the states have made in recognizing out-of-hospital residential treatment for addictions and the development of other addiction treatment specialists such as the certified alcoholism counselors that many states now certify or license. EAPs, which are self-insured, often use these services. Sometimes the treatment is much more appropriate or the cost is much less expensive. And they will get their benefit people to pay for this even though it's not covered by their health insurance policy. In effect, they'll be self-insuring for the addictions. Most states now have licensed certified alcoholism counselors, and these are people who have demonstrated through examination or continuing education that they are competent to treat alcoholism. Similar programs are being developed for drug treatment counselors. A number of states license generic substance abuse counselors. Insurance carriers who only cover physician-provided or physician-approved services are not only denying addicted persons expert and appropriate care, but they're driving up the cost by insisting that the physician services and medical backup be used and to be paid for. The insurance industry's reluctance to cover for treatment of alcoholism and drug addiction in freestanding facilities also negatively impacts the ability to treat the two groups outside of normal EAP clientele, two particular groups. Medicaid regulations preclude payment in freestanding alcoholism and drug addiction centers. This has the effect of denying treatment to poor people and effectively blocks hope of many of them of getting out of poverty because their addictions must be treated before they can turn their energies toward utilizing other programs that are meant to help them get out of poverty. Young people are also denied appropriate treatment when their addiction is one of many life adjustment problems. Many EAPs have experienced the frustration of not being able to recommend appropriate treatment for family members because the health insurance only covers medically supervised treatment. ALMACA members and EAP practitioners have provided help to workers with alcoholism and drug addiction through their employers and unions from as far back as the 1940s. We have found that help can come in many forms, and one of the most important EAP skills is the ability to match the worker with the appropriate resource. The increased number of community resources has helped us do our job, but we find that the lack of comprehensive adequate insurance for the treatment of alcoholism and drug addiction has prevented us from maximizing the assistance that can be provided to the workers. In other cases, it has meant that more was spent on rehabilitation than had to be. We believe that the health and productivity of the nation can be greatly enhanced if the health insurance industry would work constructively with the alcoholism and drug addiction community to address the three barriers to adequate health insurance coverage which I have cited. ALMACA, in closing, ALMACA congratulates the subcommittee for the opportunity to explore these issues and looks forward to working with you on designing specific legislation to lift these barriers. We would like to mention two specific areas which have been mentioned before. One is the problem with Medicaid coverage and also the impact that the bill, the minimum health benefits bill introduced by Senator Kennedy and others, would have on the availability of coverage for alcoholism and drug addiction. Thank you.
Thank you very much. Ms. Armacida.
Mr. Chairman and members of the subcommittee, I am Patricia Armacida, Director of Utilization Management for the Blue Cross and Blue Shield Association. Over the years, the Blue Cross and Blue Shield organization has been active in innovative benefit design for substance abuse treatment. Our challenge today is to offer these benefits in the most appropriate and cost-effective manner. Substance abuse is a chronic condition which often requires clinical treatment to help the individual overcome the physical or psychological dependence on the substance or substances involved. As insurers, we are very much aware that beyond its immediate effects, substance abuse can directly influence an individual's overall health status and increase their need for all health services. It is this complexity that points to the need for flexible approaches to treatment and benefit coverage. In 1983, responding to the need for innovative benefits, the Blue Cross and Blue Shield Association published a set of guidelines which identified 5 principles of benefit design. They are that benefits should cover drug and alcohol abuse, that treatment should be covered at freestanding facilities as well as hospitals, allowing access to specialized treatment, that benefits should cover inpatient, residential, and outpatient treatment, that a wide range of services, including physical and psychological testing, should be covered, and that benefit design should include annual and/or lifetime maximums. Throughout the 1980s, coverage for substance abuse has been increasing, and the gap between alcohol and drug abuse coverage has been narrowing. In addition, there has been an expansion of outpatient benefits and the offering of alternatives beyond traditional inpatient 21 to 30-day benefit programs. Despite these efforts, utilization and expenditures have increased significantly. Some employers are reporting a 25 to 40% increase in their psychological and substance abuse costs. There are some estimates that these benefits are rising at about twice the rate of other medical costs. One Blue Cross and Blue Shield plan, Independence Blue Cross of Philadelphia, experienced a 57% increase in admission rates for substance abuse in 2 years. Inpatient expenditures for these services increased more than 4-fold, from $4 million to $18.5 million over the same 2 years. Today, Blue Cross and Blue Shield plans are increasingly relying on managed care approaches aimed at providing coverage in a cost-efficient manner. Managed care is a collection of financing approaches such as HMOs and PPOs and utilization management techniques such as pre-certification, concurrent review, and case management. A number of these approaches are detailed in my submitted testimony. We estimate that over 70% of Blue Cross and Blue Shield subscribers will be enrolled in these types of benefit programs by 1990. Finally, as our testimony points out, the types of providers and programs are increasing. This means that payers and consumers are faced with the problem of sorting through differences in types of care while deciding on the most appropriate option. In addition, we find high rates of readmission among some subscribers. It is unclear whether this is the nature of the condition or an indication of an ineffective program. Outcome data and studies are needed in order for payers and consumers to be able to evaluate and identify successful programs. In summary, I'd like to highlight several points from our experience. First of all, that benefit coverage, we feel, needs to be flexible and encourage innovation, that managed care activities should be supported, that ongoing education, certification, and accreditation of individual and institutional providers should be promoted, and finally, that more information is needed as to what types of treatment are most effective and appropriate. Thank you for inviting us to testify on this very important issue, and we look forward to working with the committee as it continues its work in the area of health insurance coverage for substance abuse.
Thank you to all of our witnesses. I'm struck by how your testimony particularly has helped us to put in some sort of a larger framework the overall problems we're facing in health care, and how this particular area almost it compounds the general problems that we're having, that and to in a sense set off the difficulties of trying to deal with individual specific treatment suggestions in an area that some would regard as it's much more subjective than a traditional medical outcome, and to realize, and if your figures are accurate, and I assume they are, that our health costs in general are going up far beyond the general inflationary rate, and you're talking about mental health and substance abuse costs going up even higher than the general medical area. These are serious problems. It's important also to have the manufacturing people, or rather the business people, into this process, and they are getting involved in the process almost with a vengeance. And in some instances, if you listen to the medical people, to the detriment of appropriate medical treatment techniques that, and I'm sure you've all heard it in the same way I've heard it, the medical community lamenting the fact that we're having business people involved in prescribing treatment modes from a bottom line perspective, trying to cut costs in the minds of some medical people to the detriment of the appropriate medical treatment system that would be required. Having said all of that, all it does is compound the difficulty of the problem of dealing with this particular area that we're dealing with. And then, of course, another aspect is that the discussions we've had here are in the context of insurance payments and governmental systems. And of course, as someone said earlier, the number that everyone uses is 37 million Americans that don't have access to any health care, not poor enough to be on Medicaid or old enough to be on Medicare, aren't employed so as to have health insurance. So we haven't even addressed those folks in the context of this panel. But having said all of those things, let me just ask one or two questions with regard to some of the points that you have talked about. The whole question about drug testing in the workplace. Anyone got any thoughts as to how that impacts positively or negatively on being able to provide assistance in the workplace? One can make the, I suppose, the somewhat simplified but appropriate conclusion. If you test everyone, you find out who has the problem. On the other hand, you can make the argument that it is better to get someone to voluntarily come in to get the counseling that you're talking about, and that mandatory testing may very well drive people off somewhere. Have you got any observations about correlations between drug testing and the ability to be of assistance to people?
Let me just give a couple brief comments. I think, first of all, I think there is a major problem in the acknowledgement of the extensiveness of the problem of alcohol and drug abuse. And any kind of strategy that gets the issue on the plates of Americans, American workers and their families, is potentially a good one. My feeling about drug testing is that we rushed into believing that testing was the panacea to solve the drug abuse problem, when in fact it's a possible strategy in the context of many different strategies, and that I would hate to see the testing alone lead an alcohol or drug policy or program effort. I think that rehabilitation and treatment should be the leading strategy, and if testing is used, it should be used as a deterrent and as a vehicle to make people aware of the productivity and health consequences of the abuse.
Well, one of the things that's in the bill that we're talking about today on the House floor are provisions to deal with government contractors being required to provide for zero-tolerance workplace settings. That can take a number of different forms. One form would be testing and firing, as opposed to testing and rehabilitation. Do you have any thoughts? I assume from a medical perspective, the idea of testing and firing certainly doesn't deal with the need to try to rehabilitate that individual if it's capable of being done.
My only thoughts are that if testing is used, it needs to be used in the context of rehabilitation, and to stand alone as a policy without sufficient access to treatment and to rehabilitation is a human resource policy that in the long run will backfire for any organization.
I guess my observation from my area, where we have a fairly low unemployment rate, And we're starting to find employers who are having difficulty finding, because of the demographics changing, finding people even for entry-level skill areas. And that the employers are starting to think through the need to allocate monies to start training the employees. And I would just regard this, what we're talking about now, as just the next level of commitment to getting a good workforce. That monies in this area, likewise, are almost the equivalent of teaching someone to read. If you have a literacy problem, what you're doing is teaching someone to be more productive in the face of problems of productivity associated with drug and alcohol abuse.
Just one last comment, and that is that the fact that this committee is a committee on competitiveness, I think, is significant, because we're really talking about the value of human capital in American business, and how do you see people as appreciating assets and what you need to do to maximize their potential, both in terms of health and productivity. And clearly the substance abuse problem sits in that competitiveness context. I agree.
Let me ask, the charges for different treatment programs apparently vary substantially. I have from $5,000 to $20,000 for a standard 28-day inpatient program. How do you determine what's an appropriate fee?
In most cases, individual plans are negotiating or working with their local providers, and are sometimes using comparative data between programs to establish what seems to be a reasonable amount. Some of the range happens because of the range in days that are involved, or outpatient treatment that's included in the program. Some of the programs charge one fee up front for the whole program, others separate it by a per diem. So there's all sorts of different ways that these programs are packaged.
Let me yield to the gentleman from Utah.
Yes, Ms. Armacida. Dr. Rosen commented in his speech that mental health, drug abuse, and so on are not given as much priority on medical plans and health plans as are physical ailments that are otherwise other than those. Do you agree with him on that?
I would not agree that they're not given as much priority. Certainly, it's well known the implications of the health and medical implications of someone who has a substance abuse problem. The benefit packages for substance abuse and mental health tend to be narrower than the benefit packages for medical and surgical treatment. Part of this, I think, it comes from the insurance industry's attempt to understand and examine what is appropriate treatment for individuals and to try and design packages around that.
You do agree with Dr. Rosen that mental health should be included in the medical package, though?
That it should be included with the medical package. Not necessarily. Again, that's an area of specialized treatment. In fact, what we find in most Blue Cross...
You don't think it should be covered in the normal health package?
It should be covered in a normal health package, yes. But
even there, even when it is covered, it's covered much less, 50% or 75% rather than all like other physical ailments. Is that because we can see a physical illness and we can understand that, whereas a mental illness we somehow think they're just trying to pull a fast one or something of that nature? We don't understand. Is that the reason?
No, I wouldn't say that that is the reason. Again, if you look at traditional medical illnesses, such as surgeries that people need or the conditions of hypertension and diabetes, what your insurance package covers is services that you need throughout that illness. So if you need tests or if you need visits to the doctor, and those are what is paid for, services that are deemed medically necessary. When we look in the area of mental health and substance abuse, there is efforts to try and establish what is necessary for the individual to attain a solution to their substance abuse problem. And many of the programs were designed around 21 to 28-day type of programs, so that the insurance package was designed to support those type of programs and support those specific services, not necessarily support certain diagnoses.
I have the impression, I'll ask Dr. Rosen to comment, I have the impression that those who treat mental illness and drug abuse and so forth have had to fight and claw their way to a status with health insurance companies such as Blue Cross and others. Dr. Rosen, do I overstate the case?
I would say that mental health as an issue has had to fight and claw its way in society, and it gets reflected in every institution in America. And I think we're just starting to appreciate the role that the mind plays in the development of physical illnesses, and that is slowly getting reflected in our insurance policies and our company and management attitudes and our legislators' attitudes as well.
Do you have any alternatives to the established 28-day period that rehabilitation program is a combination of outpatient or a combination of Alcoholics Anonymous or other things? Are those alternatives reasonable alternatives?
You bet. I think that, first of all, I would say that the whole issue of tailoring and matching is critical. My big concern is that there are large numbers of workers and families and uninsured who have mental health problems, and they need some sort of treatment to get them back on track. The question is how you design the benefit in the most cost-efficient way. Certainly, some people will need inpatient care. Large numbers will need intensive outpatient care, innovative night or at-work treatments. I think aftercare and family involvement is very important. Support groups like AA and NA are critical. I don't think that there's any one profession who has the insights to treat this disease. I think all the professions, including the non-professions, are valuable in the dialogue.
In view of the tremendous loss of man hours and productivity that comes because of mental illness or drug or alcohol problems, wouldn't it not be in an employer's best interest to make sure those are covered effectively in his health plan?
Mm-hmm. I think that's true, yes.
And yet you said the great bulk of them are sort of backing away from that or not really doing what they're supposed to be doing.
Large numbers are. Certainly our goal at the Washington Business Group is to convince them that economically it's in their best interest not to retreat, but to design the benefit in a way that provides the most service to the most people at the cheapest price. And again, that is actively involving the business and union community in designing the benefit, like my Blue Cross Blue Shield colleague talked about.
One of the reasons, if I may, Mr. Chairman, one more question. One of the reasons the federal government gets involved in some of these matters is that the private sector doesn't always respond to the requests of employers and so forth. I don't know how to phrase this exactly, has the private insurance industry responded to the needs of insurance in terms of mental health, alcohol, and drug, including in coverage, reasonable rates, follow-up? Have they responded properly in this area?
The insurance industry or the employer community?
Well, I'm talking about the insurance industry now.
I think in some cases they have, and in other cases they have not. Clearly, the emphasis has shifted away from passive recipient of care from the business perspective to the active purchaser of health care and medicine. And businesses have gotten more involved, and they are trying to work with the insurance industry to provide the best treatment at, again, the cheapest price.
Thank you, Mr. Chairman. I have some questions I'd like to ask Mr. Delaney, but I'll submit them.
Let me just conclude with just an observation off of some of your testimony, Dr. Rosen, particularly the last testimony. I mean, is it unfair and overly harsh to say that in the last number of years, the business community has become much more involved in health care, in large measure because of the escalating costs, so as the cost of doing business has prompted them to not defer to the medical community as much as they used to, but to become involved and start designing their product and interact with the provider, particularly the insurance industry, and that for the most part, that concern has taken a form that is the opposite of what it is that you're advocating. A greater desire for standardization, and government in the same way, because of course, DRG systems that spell out what model units of care should be. And then when we talk about what we're talking about today, alcohol, drugs, mental health, then we start advocating the need for individual specific type of treatment modes in an area that again is not as capable of being objectively defined. You're going to find a little bit of hostility, I suspect, from those who are trying to narrow costs by having higher degrees of standardization if we try to get them enthusiastic about financing systems that, by definition, at least from what I've heard today, can't be easily standardized and are not as quantifiable in terms of traditional objective outcomes. So it's not to say that we shouldn't be trying, but it is understandable why you would apparently be having a difficult time trying to talk to some in industry about the desirability of moving in the direction you're advocating. Is my analysis?
I think your analysis is correct. I would make one concluding comment, and that is exactly why I am trying to place this issue in the context of overall competitiveness. Because if we don't look at the overall picture of why a healthy mind and a healthy body is a productive person in the society, we'll never get the full potential of the concept.
And my suggestion to one of the previous panels about if there is any way we can quantify dollar savings in the long term by dollar investment in the short term in some of these areas, that certainly is an analysis that business people would be willing to listen to, hopefully, and some in the Congress would be willing to listen to and may feel more comfortable with than a traditional analysis of talking about health care for the sake of being of assistance to people.
Well, we have that data, and I'll be happy to give that to you as much as available to date.
Fine. Thank you very much. Let me again express the appreciation of the Congress and this committee to this panel, and look forward to working with you particularly, and we'll feel no inhibitions about reaching out to you for further information.
Thank you.
There's no further business to come before the committee. The committee stands adjourned.
For more information on this hearing on health insurance and drug and alcohol treatment, you can write to the House Energy and Commerce, Consumer Protection, and Competitiveness Subcommittee in Room 151 of House Annex Number 2, Washington, D.C. 20515. Coming up next on C-SPAN, this week's Journalist Roundtable discussion after a short break for some schedule information. Good day from Washington. Tune in at about this time tomorrow for a hearing on telemarketing fraud.